All right, so we'll start with the appendicular skeletal system today. This is a follow-up of the axial skeletal system. Just as a quick review of what we'll discuss in this, the pectoral girdle and the upper limbs. We'll talk a little bit about some disease abnormalities that can occur in that area as well, and then we'll talk about the pelvic girdle and the lower limbs. Now, the appendicular skeletal system, which I'll show you in the next slide, basically demonstrates the bones that cover the pectoral girdle and the pelvic girdle. Now this illustration actually highlights the axial skeletal system, and the remaining skeletal system is representative of the appendicular skeletal system. Remember to differentiate between the pectoral girdle, think about the pecs or the pectoralis area, pectoralis muscles for the chest wall, and then the pelvic girdle, which will include the pelvic bones and then the bones of the lower extremity. The appendicular skeletal system includes bones of the limbs and the supporting elements of the girdles, whether that's the pelvic girdle or the pectoral girdle. As you remember from 2 weeks ago, the axial skeletal system supports and protects internal organs that participate in vital functions such as respiration, the cranium, which protects the brain, and the entrance ways to the body surfaces. When we look at the appendicular skeletal system, those functions that require standing, walking, writing, turning pages, eating, dressing, shaking hands, waving, a number of other functions is the responsibility of the appendicular skeletal system. Now, recognizing both skeletal systems, whether it's the axial or the skeletal system, are dependent upon the muscular system as well, and commonly we refer to both systems as the musculoskeletal system, but recognize the important relationship between those two systems. But basically this skeletal structure gives you the control over the environment, the ability to change positions in space, also provides mobility and locomotion from moving from one area to another, which gives humans the innate ability to be able to adjust their environment because of our mobility. It's dominated by the long bones. We have long bones in the upper extremities and long bones in the lower extremities as well. The pectoral girdle includes the arms that articulate with the trunk of the pectoral girdle and or the shoulder girdle, and we'll go into a little more detail about that. Pectoral girdle consists first of two S-shaped bones that are commonly referred to as the clavicle bones, or sometimes referred to as the collarbones. These are two broad, flat bones that extend in the anterior surface of the body, and then they articulate with another broad, flat bone that's in the posterior aspect of the body, which is referred to as the scapular bone. And again, I have some illustrations coming up better, or in some photos that will show you that a little bit better. Now, there are articulation points, and remember, articulation is basically where two bony surfaces will move or oppose one another. The medial anterior end of the clavicles will articulate with the manubrium of the sternum. Now, very important in the skeletal system, whether we're talking about the axial skeletal system or the appendicular skeletal system, is to appreciate your relationship between the body. Anatomical positions are important, so you're going to have to know the difference between medial, lateral, anterior, posterior, superior, inferior. So the medial end of the clavicle, is going to articulate with the sternum, specifically the manubrium of the sternum. That's the medial end of the clavicle. It's also referred to as the sternal end of the clavicle. So if I would ask you the question, the sternal end of the clavicle is medial or lateral, you would know that it's medial because it articulates with the manubrium. So articulations are the only direct connection between the pectoral girdle and the axial skeletal system. Skeletal muscles support the position of the scapula, which have no direct bony connection with the body. So the scapula basically is supported by muscles. Now we'll go into a lot more details about the muscles that support the scapula. It's, again, the scapula being the big, flat, broad muscle in the posterior aspect of the body. Let's look at the clavicle here, both in illustration and there's an actual slide as well, and it demonstrates the position of the clavicle. As you can see, it sits here in the anterior portion of the body. The sternal end, or the medial end of the clavicle, will articulate with the sternum, This is the manubrium of the sternum. You should know the different parts of the sternum, the manubrium, the body, the xiphoid process. But basically the clavicle, the medial end of the clavicle or the sternal end of the clavicle will articulate with the manubrium. Now the lateral end will articulate with the scapula, specifically with the acromion process of the scapula. And when I show you the scapula, I'll show you the different processes. Remember, processes are portions of the bone that actually protrude or project out further than the total body of the bone. So the distal portion, the lateral portion of the clavicle, will articulate with the scapula at the acromion process. So the lateral portion of the clavicle is referred to as the acromion end, or the acromial end of the clavicle, because it articulates again with the scapula, but specifically with the acromion process. And again, I'll show you that a little more. And again, the picture shows you sternal end, acromial end. You should be familiar with those two ends. It's a test question about that, identifying which end is medial and which end is more lateral. Again, sternal end, more medial, acromial end, more lateral. Now, as you can see, there are a number of other landmarks on this bone. There are tubercles, tuberosities. These are basically portions where muscles and or tendons will attach to the bone. I'm not asking you to know all of these bony landmarks. You should know sternal end and acromial end. There are in some of the other bones, as I'll talk about a little later, some particular landmarks that you do need to be familiar with. Articulations of the clavicle, again, sternal end and acromial end, roughly a pyramidal-shaped sternum. Each clavicle curves laterally and posteriorly for roughly half the length. Forms a smooth posterior curve and articulates with processes of the scapula. At the acromion, the flat acromial end of the clavicle is broader than the sternal end. Now, I wouldn't ask you the question, I wouldn't put it up there and ask you to differentiate based, because I know it's an S-shaped bone, can cause a little confusion. But if I clearly identify one end as the sternal end and one end as the acromial end, you should know which is medial and which is lateral. Now, as far as the scapula goes, a lot of bony landmarks on the scapula, some of which you should be familiar with. When we look at the scapula, again, it's a flat bone. You can see the position of it by the illustrations here in the lower right and lower left. Again, it's on the posterior aspect of the body. This would be the posterior surface when we're looking at the body from the back. If we look at the posterior surface, we see a long projection that runs across the flat surface of the scapula. This is the spine of the scapula. Then the very end of that spine is the acromion process, or the acromion. Then if we look at on the other angle, or on the anterior surface of the bone, we see the coracoid process, which again is another projection from the scapula as well. Question? That spine that's coming out, is that like your shoulder blade? That's the palpable portion of the clavicle that the scapula that you feel. So by definition, it's not truly the shoulder blade. The blade is the bone itself. But what you feel when you palpate posteriorly on your back, you feel that spine. You feel the scapular spine. And then the coracoid process, is that like this right here? The coracoid process, sometimes you can palpate, but again, the most portion of the scapula that you feel is the prominent acromial process. Now, that lies a little more deeper, and it's sometimes hard to palpate it in every individual. Depends on your body habitus. Other parts of the scapula that are important to recognize, the glenoid cavity, sometimes referred to as the glenoid fossa. This is a point of articulation with the humerus, which is the long bone of the upper extremity. It's an articulation point. You should be familiar with the glenoid cavity. I think that's on your lab portion of the exam. And again, there are particular borders, and the borders relate with the position in the body. This is the medial border, sometimes referred to as the vertebral border of the scapula. This is the inferior angle. This is the superior angle. Easy to remember. And then this would be the lateral angle, the lateral border. Now, if you look at the position of the scapula, and remember when you look at it, think anatomical position. When you look at this, remember, this is the portion that's going to be closest to the vertebral column, the way it's positioned in the body. Thus, the medial border is also referred to as the vertebral border. When you look at it again, anatomical position, you're looking at the posterior aspect of the body. We see that this spaces out laterally, thus this is referred to as the lateral border. And again, some of the other landmarks, you need to know the spine, scapular spine, and then you need to know the most distal aspect or the lateral aspect, or the end process of the scapular spine is the acromion, or the acromial process. And then the other process involved that we see when we look at the bone anteriorly, and again you have to use your x-ray vision to look through the body, you see the coracoid process. And again, to go with your question, you just really can't palpate that bone. I won't say it's impossible, but because it's anterior, you kind of got to go through the chest wall to be able to see it. And the glenoid cavity, again, point of articulation, this articulates with the superior aspect of the humerus. This is a point of articulation at the glenoid cavity. Three sides of the angle: superior border, medial border, also known as vertebral border, lateral border, or the axillary border, which is typically located at the armpit. Scapula has two large scapular processes that extend beyond the margin of the glenoid cavity, or the glenoid fossa, which is basically the superior end of the head of the humerus. And then the smaller anterior projection is referred to as the coracoid process. The acromion process is larger, most posterior process. If you run your fingers again along your back, you can palpate that. The acromion articulates with the clavicle at the acromial clavicular joint, or the AC joint. You may hear referred to in the clinical setting, the AC joint. Basically, connection between, or articulation point between the clavicle, the acromial end of the clavicle, or the lateral end of the clavicle, and the acromion process, the acromioclavicular joint. Both of these processes, both the acromion and the coracoid process, are attached to ligaments and tendons that are associated with the shoulder joint. At the scapular angle, muscles position the scapula and attach along the edges. Remember, the supporting network for the scapula are the muscles. It has no bony support at all. The corners of the angles are basically called the superior angle, the inferior angle, and the lateral angle. You should know those locations on the scapula. The lateral angle, or the head of the scapula, forms a broad process that supports the cup-shaped glenoid cavity of the scapula. And again, the glenohumeral joint, at the glenoid cavity, the scapula will articulate with the humerus, the proximal bone of the upper extremity. This articulation is the shoulder joint, also known as the glenohumeral joint. Now, there are fossas. Fossas are smooth, flat surfaces. Sometimes they are articulation point. The glenoid cavity sometimes is referred to as a glenoid fossa. It's an articulation point with the proximal end or the superior end of the humerus. But then there are also other fossas that are located on the scapula that are points of attachment for muscles. The anterior surface of the body of the scapula is relatively smooth and concave. Also, the posterior aspect, even though it's divided by a scapular spine, has a superior surface that's flat and smooth, and also has an inferior surface that's flat and smooth as well. These are referred to as fossas. Sorry, I thought I had a picture coming there. Let me go back just a little bit so we can show you that. Again, the posterior aspect, the anterior aspect of the scapula has a flat, smooth surface referred to as the subscapular fossa. Should be familiar with that term, subscapular fossa. And then posteriorly, when we look at the bone, we see a supraspinatus or supraspinous fossa. And it depends on, I'm not sure if your book refers to as spinatus or spinous, but either way, supraspinous fossa, flat surface above the spine, and an infraspinous fossa, as we see located below the spine. These are smooth areas, again, sites of muscle attachment. When we do the muscle system next week, you'll see that the muscle names will also fit these same names. There are muscles that will attach both superiorly and inferiorly, and there are also muscles that will attach on the anterior surface as well in these fossa areas. So it's important to know those landmarks as well. The acromion is the continuous portion of the bone, continuous with the scapular spine. Ridges crosses the posterior surface of the scapular body before ending at the medial border. Scapular spine divides the convex posterior surface of the bone, the scapular bone, into two regions. Again, superior region, inferior region, identified by the fossa supraspinatus or supraspinous fossa, and infraspinatus or infraspinous fossa located below that spine. The entire posterior surface is marked by ridges and lines where smaller muscles can attach to the scapula. Now, upper limbs. The skeleton of the upper limbs consists of bones of the arm, forearm, the wrist, and the hands. And again, there's some anatomical descriptions that are going to be important because you're going to need to identify what is the proximal portion of the bone, what is the distal portion of the bone, and these terms are going to be used throughout identifying skeletal structures, as you will see. Now, this is a humerus bone. This is the long bone of the upper extremity. As you can see, again, there are a number of bony landmarks here. You should be able to recognize this bone, and there are some key features that will help you to recognize this as the humerus bone. One is the greater tubercle. Again, this is a projection outside of the bone, typically where muscles and tendons will attach. There are two tubercles here. There is a greater tubercle and there is a lesser tubercle, and between the tubercles is the intertubercular groove. Makes sense? Greater tubercle, lesser tubercle. You can feel the greater tubercle when you palpate on that shoulder joint that we were talking about. If you go from the tip of the acromial process, step your finger off and you'll feel a little depression, and then you'll feel a bony prominence again. That's the greater tubercle that you can feel. Move your arm a little bit so you can know that you're on the right bone and that you're not on the acromial process. The acromion you feel very prominently here in the shoulder, but you have to make a little step off to be able to feel that greater tubercle. It may stick out, but it should be a pretty smooth surface, you know, if you had some abnormalities there. History of problem, but it should be a smooth step off. You feel the acromion process, a little depression, and then the next bone, and then move your arm a little bit, and you'll know that you're on top of it. Again, two tubercles, greater tubercle, lesser tubercle, between the two tubercles, intertubercular groove. See, they don't make that hard. Makes sense. Also, there's the shaft of the bone, and then distally in the bone, there are some other bony prominences that we'll get into in just a little bit. But I want to talk about two regions that you should be familiar with, and you should know, because I'll ask you this on the lab test. You should know the anatomical neck, and you should know the surgical neck. Anatomical neck is the point where the two bones, in infancy, when you're born, the humerus is not one complete bone. There are actually two parts. Bones grow by appositional growth. If you've read the supplemental chapter, you already know this, but bones grow from end to end. And as the superior aspect or the most proximal end of the bone grows toward the head of the humerus, these two bones will fuse, and they fuse together at the anatomical neck. So as the bones grow, they grow from end to end. When you reach that stage of growth that the bones have stopped maturing, then there will actually be a fusion together forming the anatomical neck. The surgical neck is what you see as the narrowing of the bone as it comes from the humeral head and extends to the shaft of the bone. The surgical neck is the most common site of fractures. Surgical neck fractures are important. Again, the surgical neck located on the proximal end of the bone. There are major blood vessels that run across here, also nerves that run across here that are important. So anatomically, when you identify this bone, or especially if you wanted to identify a fracture of the bone, and you call the physician or the orthopedic surgeon at night, you have a person that has a fracture along the proximal aspect of the humerus bone, then he thinks surgical neck, blood vessels and nerves pass here. Because blood vessels and nerves pass close to this area of the bone, it's a more serious fracture. He'd probably have to come in to immobilize this bone right away, versus a mid-shaft fracture of the humerus or versus a distal fracture of the humerus. Again, a little less significant. If you told me you had a distal fracture, a mid-shaft fracture, he'd tell you to put it in a splint and a sling and I'll see it in the morning. If you told him I had a proximal fracture of the humerus bone, he would probably come in to be seen. Question?
What exactly is a supracondylar fracture? Is that the one you said
Well, condylar, we'll talk about condyles in just a little bit as far as bony prominences. When we talk about condyles, I'll let you ask that question again. Infracondyle, supracondylar fracture, depends on the it's just another anatomical landmark that identifies where the area of the bone has been injured. But when we talk about condyles, we'll go into that a little bit more. I'm trying to get everybody to focus on tubercles right now. As you can see, lower in this bone, you'll see medial epicondyles. Also, when we talk about the long bones of the femur, we'll have condyles and other bony processes that we'll talk about in just a little bit. The other part of the bone that you should see is also called the deltoid tuberosity. Another bony prominence of the bone, deltoid tuberosity, is where the deltoid muscle will attach to the bone. Again, it's a little more of a mid-shaft location. But again, the bony prominence is there because it's a site of muscle attachment. And then as we move further down the bone, again, the whole midsection here of the bone is referred to as the shaft of the humerus. And then as you get a little further down, there are some bony landmarks that are important to be able to recognize. There are, at the distal portion of this bone, there are articulating surfaces. Articulating surfaces, again, where bone will meet bone and move. So the distal portion of the humerus articulates with the proximal portions of the ulna and the radius. Okay? The distal portion of the humerus articulates with the proximal portion of the ulna and the radius. They articulate at two spots. One is called the capitulum, the other is called the trochlea, and as we talk about the two bones in the forearm more, the ulna and the radius, we'll get into a little more detail about where they're articulating at. And then again, there are some other additional bony prominences here. There are epicondyles and condyles. Epicondyles, typically we see on the upper extremity bones. Condyles we'll also see can be referred to as the two articulating surfaces, the condyles. The medial epicondyle are, again, surfaces that we can feel, we can palpate. Again, the medial epicondyle, if you put your finger medially here at your elbow joint, you can feel that bony prominence, referred to as the medial epicondyle. And then, again, the articulating surfaces that you typically cannot really palpate because they oppose the ends of the ulna and the radius are the condylar surfaces. Condylar surfaces. So again, two articulating surfaces, capitulum and the trochlea, which make up the condyles. And then the medial epicondyles are basically the two bony prominences that you can see here medially on the bone. This is how you can tell the medial aspect of the humerus bone from the lateral aspect of the humerus bone. And then finally, there is another smooth surface on the bone, posterior aspect of the bone, referred to as the olecranon fossa. The olecranon fossa. Now, the olecranon fossa, smooth surface, it's smooth not because of a muscle attachment, because it's an articulating surface with the ulna bone. The proximal end of the ulna bone, articulates with the distal aspect of the humerus at the olecranon fossa. The olecranon process is on the ulna bone. The olecranon fossa is on the distal aspect of the humerus. Okay? So, anatomically, distal aspect of the humerus has the olecranon fossa. The proximal end of the ulna bone has the olecranon process, which will articulate with the humerus bone at the olecranon fossa. It's kind of the catch. And you'll see the ulna bone, the olecranon process, is kind of like a hook. And so it bends and it fits directly into the olecranon fossa and allows us to extend our arm, but we can't hyperextend our arm. Now, some people with strange abnormalities can extend, so I don't know if you're going to ask me a question about that, so I bring that up ahead of time. Some people can hyperextend their arm a little bit more, but most of us pretty much only can extend it into a linear fashion. We can't hyperextend, and if you do hyperextend, typically it'll lead to an injury. So again, those two articulating surfaces. Now, as you talked about supracondylar fractures before, if you see where the condyles are located at, and sometimes the term is loosely applied to the epicondyles, it actually would let an orthopedic surgeon know that the fracture involves the distal aspect of the bone and typically involves that elbow joint. And that's typically a pretty complicated fracture. And then you have to not only immobilize the shaft bone, but you got to actually immobilize the bone below as well, because it involves an articulating surface. So even though the fracture may only involve the humerus bone, it would only lead to further injuries if you didn't immobilize the lower portion of the bone as well. I don't know if that answers your question or not. But so each of these landmarks, not only are they important because they're sites of attachment of muscles and tendons, but also anatomically. Again, going into the healthcare profession, remember, all of us will be talking the same language, so this enables you to be able to talk with other people on the phone and clearly identify where sites of injury may be. Question?
When a person is double jointed, what is it that they...
Double jointed, more of a ligamental issue. The ligaments tend to be a little more lax. There are some specific disease disorders like Ehlers-Danlos, which people have laxity. The elastin in the ligaments typically isn't as developed in others, but that's a congenital problem. Because of the laxity of the joints, a little more flexible and pliable. Now, in this particular case, the joint itself, the bony joint itself, limits the ability to extend that elbow joint. However, in some joints, you don't see that. You don't see this surface that will actually act as a limitation in the movement of the bone. And in those joints, the person can literally hyperextend and bend their finger, in essence, and touch, the back of their hand, because there's not a bone there. It's really only joints. This particular case, you've seen the individuals that can do it. Even with their elbows, they can hyperextend. And a lot of times, they're actually moving that bone out of the joint surface to be able to do that. I wouldn't try that at home. Okay, the humerus again, also referred to as the brachium, contains one bone, the humerus, which extends to the scapula to the elbow. From the scapula to the elbow, proximal end of the humerus, round head, articulates with the scapula. So remember, proximal, the distal end or the inferior end of the humerus articulates with the ulna and the radius. So remember, proximal, distal. Proximal end of the humerus has a round head, articulates with the scapula. Where does it articulate with on the scapula? Articulates in the glenoid cavity or the glenoid fossa. Point of articulation with the scapula. Distal end of the humerus articulates with the radius and the ulna. These are the bones of the forearm, also referred to as the antebrachium. Prominent greater tubercle, rounded projection at the lateral surface of the epiphysis of the bone near the margin of the humeral head. The greater tubercle establishes the lateral contour of the shoulder. As I said before, you can palpate that. You can feel the step off from the acromion of the scapula, and then you can feel the greater tubercle. You can verify the position again by palpating that area. Lesser tubercle, smaller projection, lies on the anterior surface, medial surface of the epiphysis, anterior medial, closest toward the midline, separated from the greater tubercle by a groove, the intertrabecular groove, or the other name for that is the intertrabecular sulcus. Both the tubercles are important, or tubercles are important, because they're sites of muscle attachment, and large tendon will pass through that groove, the intertrabecular groove, and insert onto the humerus bone. Again, the two necks, anatomical neck, surgical neck. Again, one area corresponds with the extent of the joint capsule. The narrower portion, as I said, is the surgical neck, corresponds with the metaphysis of the growing bone. There's a tuberosity that's on the humerus bone as well for attachment. The deltoid muscle, referred to as a deltoid tuberosity, again, more mid-shaft location. And then there is a path that the radial nerve will follow. A and P2, you'll do the nervous system, and you'll talk more about the course of different nerves as these nerves pass. One specific nerve that you need to appreciate the course of, though, is the radial nerve. The radial nerve actually passes on the posterior surface of the deltoid tuberosity along the radial groove. The depression marks the path of the radial nerve. And again, because we see it passing close to the deltoid tuberosity through the radial groove, it's closer to the bone at that point, and so fractures in the more proximal end of the bone can cause significant problems and may even lead to vascular or nerve damage because of the path of the nerve. The radial nerve, large nerve, provides both sensory information to the posterior surface of the limb and motor control over the large muscles that straighten the elbow. The distal to the radial groove the posterior surface of the humerus is relatively flat. And then, as I've already alluded to, the epicondyles, which are near the distal articulation of the bones of the forearm. Distal shaft expands side to the medial and lateral epicondyles. The epicondyles are processes that develop proximal to the articulation and provide additional surface for muscle attachments. Now, the other nerve that's important in the upper arm is the ulnar nerve. And you should know where the ulnar nerve crosses, because all of us at one point or another have struck our elbow on a hard surface and had a sensation or tingling sensation that extends down your hand. Some of us refer to it as the funny bone, but it's not usually funny when it happens. The ulnar nerve thus crosses posterior to the medial epicondyle. Now think about that. On the humerus bone, the nerve courses posterior to the medial epicondyle. And think about your arm. Anatomical position, remember anatomical position, the hands are facing out. Okay, actually slightly curved, but let's just exaggerate and say the hands are facing out. So the medial aspect, little finger side, lateral aspect, thumb side. Okay, so the nerve courses posterior to the medial epicondyle. You can feel the medial epicondyle. The nerve is in that groove that passes posterior, so when you strike your funny bone, you know you're on the medial posterior surface of the humerus. So when I ask you on the exam, where does the ulnar nerve pass, you know it passes medially on the posterior surface, distal portion of the humerus bone. Okay? A blow to the humeral side of the elbow joint can strike the nerve, produces a temporary numbness, paralysis, tingling sensation. Typically you feel it on the little finger side because of the ulnar nerve, medial. Because the odd sensation, again, is sometimes referred to as the funny bone. Now again, points of articulation again. Articulations occur at the condyles. The humerus articulates with bones of the forearm. Those two bones are the radius and the ulna. The radius and the ulna. Now I'll show you some ways to be able to differentiate those two bones. Radius and the ulna. Now remember, ulnar nerve runs medial posterior. Only makes sense that the ulnar bone also runs medially as well. Little finger side. Small bone, little finger side. Now, the radius runs laterally, so it'll be on the lateral aspect of the body in anatomical position. That's the thumb side. Two articulation points, the trochlear and the capitulum, which I showed you. Remember, the trochlea and the trochlea and the capitulum are on the distal aspect or the inferior aspect of the humerus. The olecranon fossa is on the posterior surface, inferiorly on the humerus bone as well. So remember those landmarks. Now the trochlear is basically a spool-shaped medial portion of the condyle. It extends from the base of the coronoid process, which I didn't talk about much, on the anterior surface, to the olecranon fossa on the posterior surface of the bone. The depression accepts the projection from the ulnar surface as the elbow approaches the limitations of motion. Again, on the ulnar bone, and I'll show you the ulna in just a minute, there's a C-shaped process that actually fits into the olecranon fossa on the humerus. That C-shaped process is referred to as the olecranon process. That's on the ulnar bone. The rounded capitulum forms the lateral surface of the condyle. The shallow radial fossa superior to the capitulum accommodates portions of the radial head. And the radial head, it's called radial head because it's a circle. Remember, a circle is measured by a radius. And so radial head, and we'll show you that in just a minute, just a bit on an illustration or a picture. Medial and lateral epicondyles. The lateral head is very prominent. The differences between the medial and the lateral epicondyle makes it relatively easy to tell the left humerus from the right humerus, because if you know where the location of the medial epicondyle is, you'll be able to identify the bone. Ulna and the radius, parallel bones. They support the forearm. And as you can see, there is a process that extends above where these two bones run parallel to each other. The ulnar bones extends a little more superiorly than does the radius. That process that extends out, that projects out from the full body of the bone, is referred to as the olecranon process. That's located on the ulnar bone. Also note, the ulnar bone is larger on the proximal end than it is on the distal end. Now, it's still a smaller bone overall, probably, give or take an ounce or so, but the proximal end of the ulnar bone is significantly more larger than we see on the distal end. You also see the radius has a circular head, identifies this as the radius bone, does not extend up as far as the electronon process. We also can see that the radius bone extends a little bit more inferiorly than does the radius itself, and the radius than the ulna, extends further than the ulna does. And then also you can see distally the radius is larger than the ulna bone is. Now, one way to remember that is the little finger is small, ulna bone is on the same side, the medial surface, with the little finger, and so we know that's the smaller end of the bone. I mean, you can give the relationship. Thumb being larger, and so the radius laterally, thumb side, is going to be larger. So the finger should tell you which end of the bone is larger than the other. Remember that. I think that's a test question. Ulna, anatomical position. Ulna lies medial to the radius. The electronon, which is the superior end of the ulna, is the point of the elbow. Again, it articulates with the electronon process of the ulna, articulates with the electronon fossa of the humerus bone. On the anterior surface of the proximal epiphysis, the trochlear notch of the ulna articulates with the trochlea of the humerus. At the elbow joint, there's a U-shaped joint. Also, if you look at the hook on the ulna bone, if you turn it sideways, it makes a U, so it gives you the ulna bone. So again, that's a way to help identify the ulna bone from the radius bone. And I already told you on the radius, if you look at the top, it's a circle. You measure a circle by a radius, helps you to be able to identify that bone as well. The electronon, we're talking about the ulna bone now. The electronon forms the superior lip of the trochlear notch at the coronoid process, and it forms the inferior lip. And again, that's just the lower portion. This is the electronon. This is the coronoid when you look at the ulna bone. The lateral to the coronoid process is a smooth radial notch that accommodates the head of the radius at the proximal radial ulna joint. And again, that's because you see the electronon process will extend up further than the radius. The radius actually sits at a point at the ulna bone. It sits in a little notch, and so it's referred to as obviously the notch on the bone. At the limit of the extension with the forearm, the arm forming a straight line, the electronon swings into the electronon fossa on the posterior surface of the humerus. At the limit of flexion, the arm and the forearm form a V. The coronoid process projects into the coronoid fossa and the anterior humeral surface. The shaft of the ulna is roughly triangular. There is a membrane that will connect, or a fibrous sheet that basically connects the two bones, the ulna and the radius. It's called the interosseous membrane. It's just a membrane because those two bones run parallel to each other. The membrane connects the two bones and sits in between. Posterior and lateral surface of the ulnar head bears a short styloid process. Again, process, little bone that will project a little further than the whole body of the bone. This is called the styloid process. We see that in the distal portion of the bone. There's a triangular articulating disc that attaches to the styloid process. Cartilages separate the ulnar head from the bone of the wrist. The lateral surface of the ulnar head articulates with the distal end of the radius and forms the distal radial ulnar joint. The radius is the lateral bone of the forearm, disc-shaped radial head that you can see that makes it very identifiable on the head of the radius, articulates with the capitulum of the humerus. The shaft of the radius curves along that length. It also enlarges distal portion of the radius, which is considerably larger than the distal portion of the ulna, which we've already talked about. And again, remember, you can use your hands as the map to be able to tell you, again, small finger, ulna side, medial side, bone is smaller when you get down. The ulnar bone is smaller when you get more distal. Radius side is more lateral. The radius is on the thumb side. When it gets more distal, it gets larger. So again, the radius bone is much larger distally than you see with the ulna. And again, the notch, we've already talked about. The ulnar notch on the medial surface of the distal end of the radius marks the site of articulation with the head of the ulna. The distal end of the radius articulates with the bone of the wrist. The distal end of the radius articulates with the bones of the wrist. And I'll show you that when we show the bones of the wrist in just a minute. Now, during flexion, radial head swings into the radial fossa of the humerus. Narrow neck extends from the radial head, radial tuberosity, which marks the attachment of the biceps brachii muscle, which we'll talk about next week, large muscle that attaches to the anterior surface of the arm. On the radius, there is also a styloid process. Styloid process on the lateral surface of the radius helps stabilize the joint. If you're looking at the radius or the ulna isolated, you can quickly identify them by finding the radial notch and or the ulnar notch, remembering that the radius lies lateral, ulna lies medial. You know that's going to be a test question. How many times have I asked that? Okay. Now you're looking at the small bones of the hand. I would expect you to recognize these as carpal bones. I'm not going to ask you to give me each of the names of the bones, though some of you may want to learn those, and that's fine. I'm not going to ask you the individual names, but I would expect you to know they're carpal bones. I would expect you to be able to name specifically the metacarpal bones, which are these bones. Now, you think, oh, well, that's easy. 1, 2, 3, 4, 5. But now, look at the progression of them in order. If I ask you to start laterally and go medially, the numbering system is 1, 2, 3, 4, 5, right? If I ask you to go medial and name the metacarpal bones, you would tell me 5, 4, 3, 2, 1. Correct? Guarantee you somebody's going to miss that on the test. No, not just somebody. A lot of people will miss that on the test. Easiest question on the test, but you got to remember what's medial and what's lateral. Why is that important again? Because if you're on the phone and you give the report that the person fractured the first metacarpal bone, the assumption is that it's on the thumb side. The thumb is a very important finger. We can't use our hand without our thumb because that's the opposing digit. So if you fracture the first metacarpal bone, significant problem. Okay? If you fracture the fifth metacarpal bone, not such a big deal. Okay? But now remember that. Remember the numbering system. Starting medially. Starting medially. Give me the numbers. Starting laterally. Give me the numbers. Now the reason why this is so important is because when we talk about the tarsal bones, which are in the foot, the order changes. Numbers are the same, but the order changes. And we'll see that when we get to those bones. So recognize the carpal bones, be able to identify those as the carpal bones, be able to identify the metacarpal bones, but you got to give me the specific names because I'm going to ask you to give me the order, either starting medially or starting laterally. And then the other bones are basically referred to as phalanxes or phalanges. These are basically, if you look at the first digit, you only have two. You have a distal phalange and you have a proximal phalange. But at the others, you not only have a distal, but you also have a medial and you also have a proximal. So the others, 2 through 5, we have 3 phalanges. On the first, we only have 2. We have a distal and we have a proximal. And those are the bones of the hands. Again, I think nice little limericks are in your book that tell you all the names of these. You can memorize those names if you want to. For the purposes of the exam, I'm just going to ask you to identify these as carpal bones. I'm going to ask you to identify these as metacarpal bones, but I will ask you the specific names of those, either 1 through 5, and I'll ask you to order those either starting medially or starting laterally. Okay, and then the phalanxes, only 2 on the first digit, 3 on the rest. What's the question?
So lateral is 1 through 5 and medial is 5 through 1?
Say it one more time.
Lateral is 1 through 5 and medial is
The question was the order again. Yeah, if we start, again, anatomical position, always put, and you do this during the exam, put yourself in an anatomical position. Starting in anatomical position, number 1 starts on the thumb side for the metacarpal bones. 1, 2, 3, 4, 5. If you start medially, you're going to start on the little finger side, that's 5. Again, you're going to see the order will change when we get down to the foot, but again, 5, 4, 3, 2, 1. For metacarpal bones. The others have names. These have numbers. Okay? All right, carpus are on the wrist. 8 carpal bones. Bones are in 2 rows. 4 proximal carpal bones, and the other 4 distal carpal bones. Proximal carpal bones are named scaphoid, lunate, tracheum, and pisiform bone. Again, if you want to learn those names, that's fine. And there are little limericks that help you to remember that, and I think your book goes into detail. And then the distal carpal bones, trapezium, trapezoid, capitate, and hamate bone, the distal carpal bones. That's the little limerick that's out of your book. I forgot I had that slide on there. Sam likes to push the torque car hard. Helps you to, I don't think we used that in medical school. I think we had a different limerick, but I can't tell you that one. Carpal tunnel syndrome. Carpal tunnel syndrome. Need to be familiar with carpal tunnel syndrome. Next to low back pain, probably the #1 occupational complaint that employees have. Carpal bones articulate with one another, and they have a limited sliding and twisting arrangement. Those of you who have worked on the computer a lot, or if you've worked in a factory setting, we see carpal tunnel syndrome a lot for people who work in factory settings, especially if you work online, because you're doing the same type of repetitive movement all the time. Involves these sliding joints in our hand. Our hands can move 360 degrees, and it's because of the sliding motion. But unfortunately, the tendons and the muscles that flex his fingers pass across the anterior surface of the wrist. Now, where's the anterior surface of the wrist? It's here. Remember, anatomical position, anterior surface of the wrist. Okay, because they slide across the anterior surface of the wrist. There are ligaments and tendons that compress these tendons on a regular basis, and because of repetitive movement, a degree of inflammation in the connective tissue between the flexor retinaculum. This is a band that crosses the wrist area. We see a band that crosses anteriorly and another band that will cross posteriorly. The flexor retinaculum and the carpal bones can compress the tendons of adjacent sensory and motor areas, and it produces a pain syndrome. Can be very severe in some individuals, can cause limitations in mobility, can cause numbness and tingling, and actually can cause a degree of disability in individuals that are affected by that. 5 metacarpal bones articulate with the distal carpal bones that support the hand. And again, we already went through the numbering system that's associated with that as well. Now, moving down to the lower extremities. Lower extremities. Now we've left the pectoral girdle, and now we're at the pelvic girdle. Now, pelvic girdle, important function. It withstands stresses involved in the weight bearing and locomotion. You know, I like function questions, so involves the weight bearing and locomotion. Bones of the pelvic are more massive than those that we've seen in the pectoral girdle, mainly because it has to support the weight of the whole body. Pelvic girdle consists of 2 hip bones. Pelvis is a composite structure, includes hip bones and the appendicular skeletal system. We'll see some components of the axial skeletal system playing a role in this as well. Sacrum, the coccyx, and the axial skeleton. Each lower limb consists of a femur or a thigh bone, a patella or a kneecap, then a tibia and fibula. Remember, the fibula does not bear any weight, only the tibia bears the weight in the lower extremity. Then there are the bones of the ankles, similar to what we saw in the hands, except for lower they're referred to as tarsal bones, which form the bones of the foot. We'll talk about those in just a little bit. If we look at the hip bone, we see a combination of 3 bones. You should know these 3 bones. You should be able to identify these 3 bones. Ilium, ischium, pubis. Ilium, ischium, and pubis bones. Should be able to identify that. Should be able to identify some of the other bony landmarks here as well. One of the main points that I want you to be able to identify would be the articulating surface for the femur, which articulates on the hip bone at the point called the acetabulum. Now, we can equate that with the glenoid cavity on the scapula. This is a point of articulation with the long bone. So, referred to as the acetabulum. There's also a large hole, referred to as the obturator foramen. Obturator foramen. Large opening, again, where blood vessels and nerves pass through these little openings. This is a little bigger opening, but again, same process. You'll see a number of blood vessels and nerves will pass through this. We'll go into a lot more detail about that in AMP2. So two main important processes, and again, you should be able to identify the ischium, you should be able to identify the ileum, and you should be able to identify the pubis bone. Now, I do want you to be able to identify the posterior superior iliac spine and the posterior inferior iliac spine. Now, these are important areas, important landmarks, because it will help you to be able to identify when you have to give a shot. You'll have to actually be able to palpate these bony landmarks. You should be able to identify the iliac crest. Again, these bony landmarks are important because it helps you to get an anatomical location of the hip. You have to give a shot into the gluteus maximus muscle. You know you're in the right point of the gluteus maximus by being able to palpate the iliac crest and to move your hand laterally and identifying this posterior superior iliac spine. And you're actually able to triangulate, knowing those landmarks, and you're able to give the shot in the right location. If you don't give it in the right location, there are nerves that course deep to the gluteal muscle, which we'll show you next week, or maybe the week after, next week, week after, that course that way. So if you're in the wrong spot, you can potentially put the needle into the nerve. So it's important for you to be able to identify those landmarks. So again, I want you to be able to identify the iliac crest located on the ileum, obviously, and then you should be able to identify the posterior superior iliac spine, the posterior inferior iliac spine, and then you should be able to identify the obturator foramen, and you should be able to identify the acetabulum. Again, three bones: ilium, ischium, pubis. Ilium, largest part of the coxal bone, flared upper rim of the hip, outer edge, connects the back with the sacrum, forming the sacroiliac joint. Common bone is used in bone marrow biopsies. For those of you who may be familiar with bone marrow biopsies, in the center of bone there is marrow, basically blood, and that's where blood cells are developed and formed. In individuals with myeloproliferative diseases or problems with developing blood cells, different lines of blood cells, whether it's red blood cells, white blood cells, the immune system, doing a biopsy and obtaining a specimen of these immature cells by getting a bone marrow specimen is important. That flat bone is a very important area, ilium, in being able to achieve or to be able to tap the center, the marrow of the bone, and be able to draw a specimen. Another nice flat bone is the sternum, that you can also obtain bone marrow from as well. Again, a flat surface, hard bone on the surface, but in the center it's very soft and actually has a network of blood supply. So I just bring up that point real quickly. The ischium bone, most inferior portion of the coxal bone, ischial tuberosity, ischial spine, and the greater sciatic notch. The ischium tuberosity is part of the bone which you sit on. The ischial spine projects into the pelvic cavity. It can narrow the pelvic outlet. Now, this is important in women in childbearing years, because if the pelvic outlet is not wide enough, which is dictated by the positioning of the ischial spines, then the outlet is too narrow and the baby can't be passed, and those women would have to undergo a C-section to deliver the baby. The pubis bone, most anterior portion of the coxal bone, two bones joined together in the front form a symphysis. This area is a point of connection. It's a cartilaginous structure that holds the two aspects of the bone together. This area will expand in relationship with hormones during the time of delivery. The hormones will soften the cartilaginous structure and allow it to stretch and expand, and thus the baby can pass through this area. So in this photograph, what are the areas that you should be able to identify? Well, again, you should be able to identify the iliac crest on a lab exam. You should be able to identify the obturator foramen. You should be able to identify the sim pubis. Again, the pubic symphysis, whichever way your book refers to it as. And again, this is now the ischial spines, as you can see on the posterior view, or project into, and you can see it better on this illustration, project into the pelvic outlet. Baby has to pass through this portion, and again, if the spines are pushing a little more posteriorly and narrow the opening, the pelvic outlet will narrow. I think I have some pictures coming up, and I know your book has some illustrations that demonstrate to you the importance of the pelvic outlet. This, again, the pelvic girdle, composed of two coxal bones, the sacrum and the coccyx bones, performs three functions: bears weight of the body, serves as a place of attachment for the legs, that's relatively important, and then protects the organs located in the pelvic cavity. Those are primarily the bladder and the reproductive organs. Male versus female pelvis basically relates to childbearing. Female pelvis is broader and more shallow than the male pelvis. The male pelvis is narrow and funnel shaped. The obturator foramen, which is formed as the pubic bones fuse, they form part of the ischium. This is the largest foramen of the body. Should be familiar with that. Obturator foramen, largest foramen of the body. Blood vessels and nerves pass through the obturator foramen. Again, that's important to recognize that blood vessels and nerves pass through foramen. Oh, this is the illustration I was telling you about earlier, where you can see the difference in the male and the female pelvis. You can see the positioning of the iliac spines as well, which can narrow the pelvic outlet in female pelvis. Now, the long bone of the leg is the femur. The femur. Some bony landmarks that's important for you to be able to recognize. Let's start with the femoral head. As we had a humeral head, there's a femoral head. There is also what we see here are the necks again. There is a neck, and the neck of this bone can be a common site of fracture. There's also a tuberosity, referred to here as the greater trochanter. The greater trochanter. Again, if you palpate on your hip joint itself, you can palpate that bone. Now, commonly referred to as the hip joint is actually the femur bone, which is actually the long bone of the leg. But when a person fractures their hip, commonly either the fracture is related to the neck of the femur, or it's located just inferior to or just distal to the greater tuberosity. So common site of fracture here, approximately, both of these are proximal locations of the bone. One can be at the neck, one can be just inferior to the greater trochanter. There's a greater trochanter, there is a lesser trochanter, which we see on the medial aspect of the bone. There's the shaft again, the shaft of the femur, and then there are the condylar processes, the supracondylar ridge, which is actually a flat, smooth area that we see running posterior on the bone, and then there are articulating surfaces, lateral condyle, medial condyle, and then above the condyles are the epicondyles, which are again bony processes that we can see, bony prominences, that we can see here on the bone. Again, sites of muscle attachment, ligaments, which help to form the joint. Now, again, this articulating surface, the articulating surface that we see here on the femur will articulate with the tibia of the two bones of the lower leg. There's the tibia and the fibula. The fibula is not involved in weight bearing. Anybody know Terrell Owens, right receiver, Philadelphia? Last year had to fracture fibula, was able to play in the football game. Because he was able to play because it's not a weight-bearing bone. Now, it still hurts, and it still should be healed up before you play professional football on it, but he healed in 4 weeks or something, hyperbaric chambers and all that stuff. But my point being, and I know I'm not at those bones yet, but when we talk about the long bone and its articulation point, it articulates with the tibia, not the fibula. The fibula does not bear any weight in the lower extremity. So femur, longest bone of the body, articulates with the coxal bone, forms the hip, articulates with the bones of the lower leg. Again, that's the tibia. Head of the femur sits in the acetabulum, which I already identified to you on the hip. Two bony prominences, greater trochanter, which is lateral, and then the lesser trochanter, which we see medially. There's also another bone that sits anterior to the joint space where the femur will articulate with the tibia. That flat bone is referred to as a patella. I could go into a lot of detail about the patella, but I mean, you know, it's just a flat circular bone. It has articulating surfaces and stuff on it, but it's basically a flat, smooth bone. Tibia. Tibia also extends to the lower portion of the leg and forms the shin bone. It articulates with the femur at the knee. The tibia is a weight-bearing bone of the lower leg. There is a prominence that you can feel. Bend your knee and then palpate the bony prominence. I tell you to bend your knee so you don't get confused it with the patella, but bend your knee and you can see just inferior to the patella is the protuberance, the tibial tuberosity. Distal end of the tibia has a malleolus, which is located medially, referred to as the medial malleolus. This is a view, again, from your textbook demonstrating to you the tibia tuberosity, which you should be able to identify. And then you should also be able to identify the medial malleolus. And just as we've seen any other bones, this would be the shaft of the bone. Again, this is the articulating surface. You may have heard the term referred to as the tibial plateau, which is the flat articulating surface that we see on the superior aspect of this bone, or the proximal end of this bone. As you can see, the fibula does not reach as superiorly as we see the tibia. And so it is not involved in weight bearing. The articulating surface here will articulate on the tibia with the distal end of the femur. Now, if we look at it distally, again, the medial malleolus, bony prominences that you should be able to see. And you can also see there's a malleolus on the fibula as well. But you can see clearly where the fibula should not be involved in weight bearing in the leg. Fibula thinner bone positioned laterally alongside the tibia. Proximal end of the fibula articulates with the tibia. Proximal end of the fibula articulates with the tibia. Does not articulate with the femur. Don't let me fool you on a test question. Lower end forms the lateral malleolus. And then we're down to the foot. And then as we look at the foot, oh wow, we're doing good. Then as we look at the foot, there are tarsal bones, just as we saw in the hand. There are tarsal bones in the foot. Tarsal bones, again, I would expect you to recognize them as tarsal bones, with two exceptions, and I do want you to know these two bones in the lower foot. I want you to know the calcaneus, and I want you to know the trochlear of the talus. This is the calcaneal bone, largest bone of the largest of the tarsal bones in the foot, and then we see the trochlear and the talus of the trochlear of the talus bone. And the reason why that's important is that's an articulating surface. This is what's going to be articulating with the tibia bone. So you need to know those two specific tarsal bones in the foot. Talus and the calcaneus. Articulating surface of the talus is the trochlear. Then the rest are basically tarsal bones. And then here comes that numbering system again. I do expect you to know. You wonder why I'm making you know because they're Roman numerals? Because it'll help you to know medial from lateral. And you got to know medial from lateral. And again, the numbering system changes on the when we talk about the metatarsal bones. Again, remember we had metacarpal bones. These are metatarsal bones. And again, if you start more medial, you see that the large bone, the largest of the metatarsal bones, is number 1, beginning medially and going laterally 1, 2, 3, 4, 5. I can't show you my toes like I did the hand. And when we start laterally and you go medially, you start 5, 4, 3, 2, 1. So you should know the order differences between those two, just as you had to know the ones for the carpal bones. And then we see the phalanxes are basically set up the same. Only 2 phalanxes when we look at the large metacarpal bone, followed by 2 small phalanxes, a proximal and a distal. And then the others have not only a proximal, but also have a medial and a distal. So the others all have 3. Tarsal, metatarsal, and phalanges. 7 tarsal bones from the ankle. Most proximal tarsal bone is the talus, which you do have to know. Most of the weight is bared there in the articulating surface of that is the trochlear. The instep is formed by the metatarsal bones. There are some congenital abnormalities that can occur, congenital talipes equivaris, which is also known as clubfoot. And as you can see in your reading, the figure skater Christy Yamaguchi had the clubfoot when she was small, but it is a correctable process. Many children can just wear specific braces. Some would require surgical treatment, but it is a condition that can be corrected with appropriate management.